Hey, so welcome everybody to the association's presentation today on SEAL training, which we're calling the Simple Effective Appeal Letter. My name is Denise Wilson. I'm your host and your presenter today. And man, we got a big crowd today, so I'm going to go just a little bit slow here at the beginning to allow people to get logged in. You know, we've always have a handful of housekeeping slides we have to get through anyway. So let's go ahead and get started. If you're new to GoToWebinar, you should have a control panel that you have access to, and it will allow you to select if you want to listen to the audio through your computer or if you want to call in. You can also download the handouts for today's presentation. Go to the Handouts tab and open that up, and you can download it. If you're having trouble with the download, because I know sometimes you've got, firewalls on your systems, if you're at work, it may not allow you to download. You can try going to our association website, www.ahdam.org, and the handouts are there on the home page. Just scroll down slightly you'll see them kind of at the top of the home page. They're in orange, and just click on there and you can download them from there. Of course, your system may still block you from downloading them, but it's another option to try. If you can't download them at all, you can email me at denise@ahdam.org, and we'll send those out to you after the presentation today. If you have questions about the content today, I'm going to try to allow a little bit of time at the end to answer as many questions as I can. So just put those in the questions panel on your control panel, and I will try to get to as many of those as I can, as I said, towards the end of the webinar today. CEUs. Free CEUs are offered to our AHDAM members only, so you have to be an AHDAM member as of, I'm going to say, midnight tonight. If you want to sign up afterwards, I'll still allow you to have CEUs. You have to attend a live webinar for at least 50 minutes, so make sure you stay on till the end. And there's a survey that will pop up automatically for you at the end of the webinar, and you have to complete that survey. It will just pop up automatically on your screen. If it doesn't for you because you have pop-ups blocked or whatever at your facility, just let me know. I can email you a copy of the survey, and you can fill it out and send it back to me. CEU certificates will be emailed to you. We try to get them out within about a week. We do have to make sure you complete the survey, that you're on 50 minutes, and you're an AHDAM member. CEUs are not available if you're watching the recording of this live webinar. We are recording this. It will be available on our website in about a week. CEUs are not available for watching the recording. So when you do the survey, at the end of the survey, you'll be prompted to select the CEUs that you want. You can select as many as you want. We have active, NARI, CCMC for case managers, AHIMA, and ANCC for our nurses. So just select as many of those as you would like, and we will email those to whatever email address you registered for the webinar. Our next complimentary webinar is going to be June 22nd, Fighting Readmission Denials, and this comes from you all. You told me at the last webinar, I always have the question on the survey, what do you want to hear in the future? And a lot of you said you wanted to hear about readmissions. So that's going to be our next topic in June. And it's available to register now. If you go to our homepage, scroll down below the registration for today's webinar, and you'll see there's a link that you can register for our next webinar in June. Okay. The next largest topic or greatest topic that you all want to hear about is clinical validation. So we do plan to do a clinical validation webinar I believe it's going to be in September. So that's coming. A little bit about our association. We are the nation's only association dedicated to healthcare denial and appeal management. So our mission really is to support all of you who are working in that field of healthcare insurance denial and appeal management. It really is becoming its own sector of healthcare. It's becoming recognized as another area of revenue cycle So we want to be here to help support you through education and collaboration. And our vision is to help create an even playing field so that you as a healthcare provider are successful in having that conversation with the payer and persuading them to make proper payment decisions when they are considering your claims. So we just want to make sure that you are as well versed in having that appeal conversation with the payers as the payers are in, making those denials. So that's really our goal. As I said, my name's Denise Wilson. I'm Senior Vice President at Denial Research Group, better known as Appeal Masters. I'm also president of the association. Been in healthcare my entire adult career, so over 30 years. I do a lot of education these days, managing the association, doing webinars, doing speaking engagements. We used to do on-site education. I still do education via the web since we aren't doing so much on-site these days with the pandemic. But that's kind of my role these days. A disclaimer that we publish and distribute materials on our website that are created by our members or invited industry subject matter experts for the benefit of our members, and we do not certify the accuracy or authority of these materials. They are distributed and presented as research information only to be used by AHDAM members in conjunction with other research that you may deem necessary in the exercise of your own independent professional judgment. We claim no liability in relation to reliance on content of the materials, and the views expressed are the views of the materials authors, do not necessarily represent the views of AHDAM. Any references are provided for informational purposes only, do not constitute endorsement of any sources. And there are no conflicts of interest to declare for any individual in a position to control the content of this presentation. Okay, so our learning objectives for today. We're going to focus on 5 areas of medical record documentation for support of the inpatient admission. Now, I know there's some coders who have registered for the webinar today. I know there's some CDS professionals who are on the webinar today. We're going to focus on level of care or appealing a denial for an inpatient admission. But I do think some of the things that I'm going to talk about today, you could apply those in your work doing coding appeals or CDI appeals. But I just want to be clear from the outset that today I'm talking about inpatient admission appeals. We're going to identify 2 sections of the history and physical that contain the most valuable information to include in the appeal for inpatient admission, and then at least two objective patient assessments that support the patient's need for the admission. Here's our learning objectives for nurses. When I get the CE for nurses, they like us to write our objectives a little bit differently than I do for the other associations, so I just need to include those here so that those of us who are nurses know that our objectives have been approved by our nursing association. Okay, so let's get into the meat of the presentation. So why are we talking about a simplified appeal letter? What's the purpose of using a simplified appeal letter? So, up until a few years ago, we did a lot, you, me, you guys on the call, did a lot of appealing for level of care to traditional Medicare. That was like the big bulk of the appeal work we were doing, especially because the recovery audit contractors were so heavy-handed in denying inpatient admissions. So we wrote our appeals in a way that we were writing to an administrative law judge, which is your 3rd level of appeal for Medicare. You go in front of an administrative law judge and plead your case. That ALJ is not a clinician. He's really all about fact finding, and he looks at the case, he or she looks at the case in a holistic way, meaning they're interested in understanding the patient as a whole. And today, the vast majority of the appeal work that we're doing, especially for level of care denials, we're appealing to commercial payers and managed care payers. That's a different audience than the administrative law judge. Instead of going to the administrative law judge, now we're going to clinicians, and we're trying to get our cases to external review, which is a clinical review. we're trying to get these outside the court of the payer's opinion and go to external review. And I have a whole webinar on, it's called The Road to External Review. If you're not real clear on what external review is or what that means or how you get there, it's the webinar recording is on our website and it's free to watch it. So I would encourage you to watch that webinar as well. So the payer's clinician reviewer who's looking at your appeal and looking at your case, they're looking for a few key points because they're really using a checklist or guidelines, and that's how they're basing their decision. It's not necessarily on a holistic look at the patient. Sometimes it's not as much on, the entire clinical picture of the patient, but it's more based on guidelines and checklists. For example, little concern for social factors, which when we would go to the administrative law judge, we could talk about how the patient was lived alone or was homeless or couldn't afford their medications, and the law judge would take that into consideration, but we don't see that with the commercial payers or managed care payers. So the approach needs to change just a little bit for this new audience that we're writing appeals to. The reason I call it simple is equivalent to being efficient, a simple, efficient process, because when you're writing appeals, there has to be that balance between being effective and being efficient. Yes, you have to be effective. You want to be effective because that's your job, right? To write appeals that are going to get those denials overturned. But we have to be efficient as well because we don't have all day to write an argument. Staffing is tough these days. I mean, I've heard that off and on throughout my entire career, that we're in a tough staffing situation. We can't find good qualified staff, but it really is ringing true now when so many people have left healthcare because of the pandemic or for other reasons. So you've got to have a process that is efficient so you can do more with less. Hate to say those words, but that's kind of what it's like, and that shouldn't be new to anybody who works in healthcare. You're always being asked to do more with less. So let's be efficient as well. It's costing money to go after these dollars. Let's make sure we're spending that money in a wise way. So being efficient means understanding, gathering only the significant, relevant clinical documentation that supports the services billed. So I see oftentimes, especially with nurses, I'm a nurse, so I'll say it feels like they're the ones who really like to dive into the record, to look, take it apart piece by piece by piece and write a lot about what was going on with the patient. Physicians, I find, are a little bit more succinct in how they write their arguments. So let's retrain ourselves to be more succinct, more focused in our appeal arguments, and make sure that our arguments are aimed at the root cause of the denial. So it's a little bit of a just the facts, ma'am type of approach, which is different than how we would write to an administrative law judge who's not a clinician. Effective. So if being effective means incorporating those essential clinical, administrative, or legal arguments in your appeal. Now, I do have a full appeal letter that we're going to look at towards the end in Word format for you all to see. I'm going to try to get it posted for our AHDAM members on the AHDAM website this week or next week. So we're going to talk about the essential clinical arguments. There's a little bit of an administrative argument in the sample appeal that I'm going to share with you all. I'm not going to talk about legal arguments, and there are no legal arguments in this letter that I'm going to share today, because we're going to do a webinar in July on legal arguments or legal snippets that you can incorporate into your appeal. And I'm thinking about calling it legal snippets for clinicians, kind of like, legal snippets for dummies. Let's call it legal snippets for clinicians. They're legal snippets that you as a clinician are going to be able to understand when to use them. Okay, they're pretty commonplace snippets, but they're important to have in your arguments, because when you go to external review, if you go to arbitration, mediation, whatever, you've got some legal arguments already built into your letter. So the letter I'm showing you today is going to be clinical administrative. I made sure it didn't have any legal arguments in it because I don't want to get into that today. So it incorporates the persuasive arguments in support of the services billed. That's your closing argument. And then it's built in a standardized format that's tailored to take you to external review. And you'll see more of that when we do our webinar in July on the legal snippets, okay, legal snippets for clinicians. So here's what we're going to focus on today. I'm going to talk about 5 areas of the medical record. So as a clinician, as you're writing your appeal, if you touch on these 5 areas of the medical record, the vast majority of the time, you're going to have everything you need to write a good, strong argument, okay? Other areas of the medical record probably don't even need to touch. Okay, so this is what I mean by let's get focused and let's make it succinct by going to these 5 areas of the record. So the first one is a registration sheet where you might see authorization for services and the type of insurance. Okay, so that tells you, is it traditional Medicare? I'm going to write my appeal a little bit differently. If I'm going to the administrative law judge, if it's commercial or managed care, I'm going to write it the way I'm going to show you today. It's going to be the seal appeal, the seal appeal. The ED record, that's where you're going to find most of the information. If they came in through the ED, I know not everybody comes in through the ED, but the ED record, the nurse's triage notes, vital signs, if there was a failure of outpatient treatment, the ED history and physical objectives, your aberrant labs, and what is known at the time the decision is made to admit. And if they get placed in observation first, and maybe they go to the floor to an observation unit before that decision is made to admit, there'll be additional information in the record that you're going to want to look at to determine what did the physician who makes that decision to admit know at the time that decision is to made. That's why I have in there, unless they're placed in obs first. If they're placed in obs first, there's going to be information outside of the ED record that you want to consider. Number 3 is admission history and physical. Again, thinking about what is known at the time of the admission decision, because some additional testing may have been done as with the patient observation, outpatient in a bed, before that decision is made to admit. And the plan of care, I think, is super important on the history and physical, but that really tells us why that patient needs hospital care. Labs, radiology, and operative reports. Obviously, operative reports, they're not in surgery when they're in the ED, so those are going to happen after they've left the ED. But any labs and radiology that significant abnormalities that were not noted when the patient was in the ED. And then the discharge summary will give you a nice, clear picture of what happened while the patient was in the hospital. Now, I always talk about focusing on what's known at the time of the admission decision, so why look at the discharge summary? Some things can happen after the patient is admitted to the hospital that I would not hesitate to put in my appeal argument, because it could support the concerns that the physician had for admitting that patient. So the physician's admitting that patient because he has a concern that the GI bleed is going to turn into, anemia, or it's going to advance and the patient's going to require emergency surgery or whatever. Of course, he doesn't know that's going to happen, but he has concern that it's going to happen. And so things that happen after they're admitted can help support that physician's decision to admit. I hope that makes sense. Okay, so let's go through those 5 areas of the medical record. Now, starting with the registration sheet, there's not a ton of information you're going to get on here, but it's worth a glance. It's kind of where I start. It's usually the first page in the medical record anyway, if you have your medical record printed out. There may be, now in some in some cases, for some hospitals, I see where on the registration sheet, they may have an off number or a pre-cert number. And you can see on this one, they actually have, it's the same number in both of those fields. Those aren't always true authorization numbers. That doesn't mean that they actually did get authorization for the admission. Those could be reference numbers where your department has contacted the insurance and this is the reference number for that case. That doesn't mean necessarily that the insurer authorized it. Okay, so just a little writer beware. I just wanted to throw that in there. As I was looking through cases to find one to demonstrate today, I ran across that and said, I just want to throw that out there. So this is a case I'm going to present today. Now, full disclosure, as I looked through a couple of dozen cases to try to find one that had a lot of good information in it that I wanted to talk about today, this is the case that I settled on. Now, you're going to see this and you're going to go, well, this was a slam dunk, Denise. I can't believe it was even denied. I want to see one that was a tough one that you appealed. And I agree, and I'm going to try to find a tough one to set up as a case study for y'all to see. But try not to focus on that. Let's just focus on, today I just want to talk about being efficient and which pieces of the medical record you want to look at when you're writing your appeal. Okay, so don't get hung up on, yes, this patient should have been inpatient, absolutely, probably met all kinds of criteria, payer criteria for admission. And in fact, the payer came back in their denial and said, we checked it against MCG. We don't really have enough information to determine whether this patient meets, the payer's criteria to be an inpatient. So really the reason this case denied was because the provider didn't send enough information for the payer really to make a good decision on whether or not they were going to authorize an inpatient admission. So that's a whole nother conversation. We're not going to talk about that today. Okay, so I just want to get that out of the way because I know you're all thinking, well, this one should have been paid. You're right, it should have been. And that brings me to a question. I do have a little poll I'm going to bring up a little bit later in the presentation that asks, when you're faced with a denial that's based on screening criteria like this particular appeal, what is your appeal methodology? Do you argue the screening criteria was misapplied? Do you argue standards of care to support the admission? Do you do a little of both, or do you do something different? Don't answer now. Don't put it in the Q&A. I'm going to pull a poll up and you'll be able to select your answer. I'd be interested in finding out what you all do as your norm when you're presented with this type of a case. Okay, so let's talk about the emergency department documentation for this gentleman. Okay, that's our section number 2. So there wasn't a whole lot of triage nurse notes in here. We do have vital signs showing he was tachycardic and he was tachypnic. He was brought in from home for alcohol withdrawal and hyperglycemia, and he was complaining about vomiting. And there's more information from the physician's history and physical. That's what I got from the triage nurse notes and the vital signs. So here's the ED history and physical, and what I have bolded here are just those pieces of the history and physical that are included in the appeal letter that says, this is what's going on with this patient. He was having constant moderate nausea, vomiting, abdominal cramping. He's diabetic, abdominal pain, chest pain, shortness of breath. He'd been on a binge drinking regularly for the 3 weeks prior. And over the last 24 to 48 hours, he was having vomiting, increasing shortness of breath. He was concerned that he could be in diabetic ketoacidosis, and he was complaining of chest pain. Okay, so there's our ED history and physical. In the ED department, let's look at our aberrant labs and diagnostic studies. Now, he did have an EKG, and it was normal. And I'm not going to talk about that in my appeal. If it's normal, I don't need to discuss it. I'm going to focus on what's abnormal. And this guy's got a lot of abnormal going on here with his labs. Not only having some very high and very low values, but also some critical values like his pH. 6.88. His blood sugar, random blood sugar was 513. So this guy's, got a pretty sick. We've got a pretty sick gentleman here. Okay, while we're in the ED, what treatment was rendered in the ED and how did the patient respond? And again, you'll probably see, most often we'll see that from the physician's documentation. So look for that ED physician documentation. This is what the ED physician had documented, that this gentleman had severe acidosis, pH less than 7. They did give an AMP of bicarb, started an insulin drip. He has a significant elevation of anion gap, discussed with the ICU attending. Yes, he did get admitted to the ICU. So that was their plan, to admit him to the ICU due to the degree of his acidosis, acidemia, and his anion gap. So what is known at the time of the decision to admit? This is what we know. And we know that after discussing with the ICU attending, the decision was made to admit this patient to the intensive care unit. So this is what our patient looks like at that time. Okay, now we can jump over to the admission history and physical. Okay, so this is after the patient's been admitted. And I think the two pieces of the admission history and physical that are most important to look at when you're formulating your argument is the history of the present illness and then your plan of care. Okay, there's other things in there like their home meds, their family history, things like that. Really not important. We want to focus on the history of the present illness and the plan of care. Okay, so this is what the admission history and physical stated. So what I'm looking for is really anything that wasn't in the ED notes, because I don't want to go too far past the time the decision was made to admit, but anything that the admitting physician saw or knew about when he made that decision to admit that maybe wasn't documented in the ED. So in this case, I see he's got chronic pancreatitis. I didn't see that in the ED notes. Chronic pancreatitis in the setting of alcohol abuse and hypertension. I didn't see hypertension in the ED notes. He does not have an endocrinologist or primary care doctor. I didn't see that in the ED notes. So that can help us understand as well that this patient probably doesn't take very good care of himself at home. Also, once the patient arrived in the ICU, he had some dark brown emesis, streaks of bright red blood, and he was given protonics and started on a protonic strip. Now, that's after the decision was made to admit, but I left it in there because it's part of the physician's care plan. So that's why I have it on this slide, so you don't wonder when I go to show you the care plan, where did the protonic strip come from? And the impression from the admitting physician: alcohol abuse with withdrawal, diabetic ketoacidosis, acute kidney injury. So his plan of care, so this really speaks to, needing hospital care. And yes, I know it's a slam dunk, should have been inpatient all along. He got an AMP of bicarb, he's on a DKA protocol, he's on a bicarb drip, he's on an insulin drip, he's on a protonic drip. They're going to do BMPs and BBGs every 2 hours. Endocrinology is being consulted, and so definitely supports that admission. Okay, then jump over to our labs, radiology, and operative report. Again, we're just kind of doing a quick glance through those to see if there's any objective abnormalities that maybe were not noted in the ED report. So these are your objective findings that help support that admission. One of the things that I look for sometimes is I will look for the difference between what the ED physician's, his read of the radiology reports or the chest x-ray versus a radiologist report, or the cardiologist report on the EKG versus the ED physicians. Now, if they don't read them until 2 or 3 days later, I don't know if that really supports my, suggestion that we focus just on what's known at the time of the admission. But that's one of the things that I look at when I go to labs and radiology. What did the radiologist say? What did the cardiologist say? And then the discharge summary, which includes your consultation notes. So you could read through the consultation notes if you want to, you know, if the endocrinologist comes to see the patient, if a nephrologist came and saw the patient, you could read through their notes, but you'll probably see a good summary of what they saw, what they thought, what they did for the patient in your discharge summary. So you could just skip there and see if there's anything else you want to add to your argument. I always think of, you know, the more physicians that are involved in the patient's care, the more complex the care is, or the sicker the patient. So it's always worthwhile to talk about the different specialists who came and saw the patient, or were at least consulted to see the patient. And then this is the piece that I think is the most important. After you've presented in your appeal letter, you know, the patient's presentation, tying that all together. And I think this is where I see a big opportunity for education. It's how do I pull all of that information together to make that persuasive argument that that patient needs to be treated in the hospital. So the closing argument starts with just kind of a little review of what happened with that patient, what he looked like when he came in, how he was placed on IV fluids, started on insulin protonics, bicarb drip, monitored in the ICU, before possibly going into respiratory failure, diabetic coma, or suffering a severe GI bleed. So those are the things that we're concerned about, or the physician was likely concerned about, whether he documented or not. Those are the things that we know could happen when a patient presents with this type of presentation, and why he needed hospital care to prevent those things from happening. Okay, the purpose of why he was in the ICU, you know, his blood sugar levels. We didn't want him to go into a coma or suffer respiratory failure. Monitoring electrolyte disturbances, making sure that we're fixing the acidosis. He could go into acute encephalopathy, internal bleeding, kidney function. We've got to make sure we get his kidney function back to whatever this gentleman's baseline was. And to wrap it up, the severity of the presenting signs and symptoms and intensity of service provided met the standards for the higher level of inpatient care. Okay, so a good persuasive argument. And it's not a big, you know, it's a paragraph, 4 or 5 sentences. So when do you know that you have enough? When is enough enough? So let's talk about the 5 W's in your narrative argument. Number 1, who is the patient? So the demographics, any significant, impactful, I have social factors in the narrative. I probably should have left that out. Not as concerned really with the social factors for commercial and managed care payers as we are with, as I said, with administrative law judges. There's signs and symptoms, any comorbidities that might be playing into that patient's condition. When and where were they admitted? Were they admitted to inpatient? Were they placed in observation first? And the physician decision-making, the status of the patient at the time that decision is made. And then why do they need inpatient? Severity symptoms, intensity of services, risks of adverse outcomes, unstable comorbidities, failure of outpatient treatment. You can use, and we have used this for traditional Medicare cases, average length of stay of the DRG. And the administrative law judges that we've talked about this in front of have been very interested in knowing what the average length of stay is for a DRG. Now, that's a little bit different situation because we're talking about traditional Medicare and the 2 midnight rule, and saying, well, yeah, we would expect this patient to stay 2 midnights because the average length of stay for this DRG is 3 days or 4 days or whatever. So you can use that, you know, in your commercial appeals as well if you want to. I'm just saying I've seen that be more of a successful argument in front of administrative law judges. Okay. So let me show you the, not there. Let me show you let me go back here. There we go. Let me show you the appeal letter itself. Here we go. Okay. So this is obvious has been redacted. I've changed the names and dates of service and things like that. But this case is overturned. No surprise, right? So let's go down here. If you've been to any of our webinars before, you know this is kind of the format we use to kind of set the stage for our cases. It has the patient's demographics. It has their comorbidities and complicating factors, procedures that were done. And we have a little summary of the denial. So here's where you can see that this is a little bit of what I was saying about an administrative part of your appeal to kind of tell the payer right up front, we know you used MCG criteria, you actually used the diabetes criteria. So this is kind of a standard argument that says those criteria are an objective tool to help guide physicians in their decision making. Okay? They don't always take into consideration specific comorbid conditions that could place our patient at a greater risk of adverse outcomes. The decision to admit is complex, goes far beyond MCG guidelines. The attending physician has to evaluate the entire presentation, including acute and chronic comorbidities, in determining, the correct status for the patient. MCG is not designed to replace the physician's professional training and expertise. So that's a stock statement that you can include in your appeal letters. You could put interqual in there, MCG, or whatever criteria the payer is using, and say, that is just a screening criteria. We object to you using it, as a payment policy and not considering the entire picture of the patient and the physician's complex decision making. Then our justification for appeal, this is going to be the narrative that includes, you can see that first paragraph includes the patient's presentation in the ED, the signs and symptoms that the patient had, their abnormal lab results, and how he didn't have an endocrinologist or a primary care physician, and the treatments that were started in the ED, the IV bicarbonate, continuous insulin infusion. And we always put in our appeal letters as well, I would recommend, if you're able to, if you send your appeals in as like a PDF document or on paper, heaven forbid, I know some payers are still accepting paper only, to put your page numbers in your medical record and point your reviewer to where they can find that information in the medical record by citing those page numbers, or at least cite which documents in the medical record where they can find this information. Hey, make it easy for them to find in your favor, okay, by being able to find that information in the record. Our second paragraph talks about his admission and what he was assessed with, okay, his alcohol abuse withdrawal, his diabetic ketoacidosis, his metabolic and respiratory acidosis, superimposed metabolic alkalosis, acute kidney injury. It does talk a little bit about the arrival to the ICU and the IV protonic, and the CWAP protocol, the telemetry, and all of that. So that's a little bit of the physician's plan. So we've got our ED presentation, and then we've got our history and physical in our plan in our second paragraph, and then our third paragraph you already saw. That's our summary to kind of wrap it all up. So that's what I mean by simple and efficient. Okay, so each piece of the medical record that we touched is kind of, its own paragraph or combined paragraph there. We didn't have anything additional when we looked at the labs. There wasn't really anything additional there for us to be adding, and there wasn't anything in the discharge summary really to add to our argument. Okay, the other thing that we do as well, or I recommend as well, is to talk about the standards of care in the medical community. So that kind of brings it, kind of plays back into that question of, for a case like this, would you argue that this case met MCG, Or would you argue that it meets standards of care for admission, or a little of both? This one we went with arguing that it met standards of care. So these evidence-based guidelines are templated into an appeal letter template, okay? So they're already coded into our appeal letter template for this particular DRG. So something that you all can do as well is look at those standards of care, pull those snippets out that help support an admission for diabetes, for example, in this particular case, and have them already templated into a letter, a Word document, so that you can use those arguments when you're arguing for an admission for your diabetic patient. So this particular guideline talks about how diabetic ketoacidosis occurs mainly in people with type 1 diabetes, and this gentleman had type 1 diabetes. So you see the things that are bolded are what apply to this patient, what's specific to this patient. You could take this information and pull it up into your summary if you wanted to. And you could say, according to so-and-so study, or according to so-and-so journal, according to American College of Cardiology, or whatever physician professional organization. We know that diabetic ketoacidosis and hyperosmolar hyperglycemic states are both life-threatening conditions caused by a complete or relative lack of insulin and require emergency hospital admission. Now, when it's a clinical study and they say admission, yes, they don't say inpatient admission or, outpatient in a bed in the hospital. But I would argue that when a clinical journal article states hospital admission, they mean inpatient admission. Okay, that's what they're talking about. We have another evidence-based guideline here. This is from American Diabetes Association. That these are the ones that I love, that give you a list of indications for an inpatient admission: life-threatening acute metabolic conditions, institution of insulin pump therapy or other intensive insulin regimens, diabetic ketoacidosis, which our gentleman had. Okay, so those are just two standards of care that we used in this particular appeal. And again, you could pull that up into your narrative if you wanted to talk about that in your arguments or in your summary. And then just a little conclusion at the end there. Okay, let me pull up. I want to pull up the poll, and then I'm going to check to see if you all have any questions I can answer. So let's pull up the poll and see, how do you all like to do your appeals for these types of cases? I'm going to go ahead and launch the poll, and I'll leave it open for a couple of minutes. Okay, interesting. Okay, I'm going to go ahead and close that down. And let me share that with you. And pull this over here. So that's really interesting. The vast majority of you, 70%, said you do a little bit of both. screening criteria and standards of care. 22% say standard of care, 5% said argue that the screening criteria was misapplied, and 3% said something else. That kind of surprises me a little bit. I really thought more would say screening criteria was misapplied. So there was some just a short discussion in the community recently about what, how should you approach these types of denials? And a lot of folks said they felt arguing standards of care was really the way that we want to go about, approaching our denials, approaching our appeal methodology, I guess, for these types of denials. And I agree with that as well, that we should use standards of care. But I also kind of feel like, if they're going to use, because if you argue back the screening criteria, it's almost like you're saying you agree with that as a payment methodology. But screening criteria is based on standards of care as well. It's not the best way to determine, whether the patient should be inpatient or outpatient. I don't think it's not always it has some of its own faults. So it really should default to standards of care. But anyway, very interesting. I'm a little bit surprised with that, but I'm kind of happy to see it too. And a little bit of both. Why not, do it both ways. Okay, well, let's see if we have any questions. If you have any questions for me, you can put them in the questions box. I know someone asked about including the sample appeal letter with the posting of the recording. So the recording will be up on the website, like I said, in about a week. We get it up there usually shorter than a week. I'm going to post the sample appeal for our members only, just as another, perk of being a member. So I'll send something out in probably next week's email. I usually try to send a weekly email to you all about what's going on in the association. So I'll let you know when that's available if you are a member. Do you have a sample of a successful appeal letter? Well, I just showed you one, but like I said, I will try to find one that was a little bit more, not so cut and dry. This one was kind of a slam dunk. The patient should have been inpatient. Let me see if I can find another case that's a little bit harder and get that posted on our website as kind of a little case study. Can you do a presentation or explain how you can use these principles for clinical validation denials? That's a good question. Let me check with our CV team and see if there's something that they would that they have that we could share in the future for those of you who are doing clinical validation. Let's see, we asked for MCG guideline to see what the payer uses. However, we do not have an easy time acquiring them. Any tips? That's a good question. There are regulations that state regulations that say the payers have to supply you with whatever criteria they use to make their decision to deny. Now, I know some of them are hiding behind the fact that, well, that's proprietary, I can't share it, it's copyrighted, blah, blah, blah. I would not let that hold me back. I keep asking for it until I get it. So if you want, look at your state regs that cover how insurance, your state board of insurance there would be some legal regulations in your state that talk about how they have to provide you with that information. I would use that to push back on them. Okay, every state's going to have that. Do you think the payers, some of these are a little bit more in-depth questions, and I will answer those in our Q&A that we post after our webinars in like a week or so. So I'm going to skip over a couple of them. Do you think the payers are reading all the evidence-based guidelines in your appeal letters? I don't know. if they're reading it or not. But really, the reason for having it there is when you go to arbitration, mediation, external review, to be able to make that argument that your care that you provided meets the standard of care. Okay, so whether your payer is actually reading that or not, who knows? But it's there. You've made that argument from the very beginning. It's there for you when you get to if you have to get to a more legal process to try to get your cases resolved. So you just Google when you're looking for standard of care guidelines. No, we actually have, when we create our standards of care, we actually have certain criteria that we look for. Okay, so like one of the first places we'll go to is the physician professional societies and see what they have published as far as standards of care. We'll look at some of the supporting organizations like American Diabetes Association, the gold standard for COPD, that's the Global Obstructive Lung Disease report that comes out every year that says these are, this is when you need to admit your COPD patient with an exacerbation. So we look through those. We go through peer-reviewed journal articles. We look for things published in the United States. We try to look for stuff that's not more than 10 to 15 years old. We try to stay within 5 years. That's not always possible. So no, we have a whole set of criteria that we use when we look for standards of care. Okay. Okay. How long does it take to write that appeal? So that question comes up a lot. That's kind of like, everybody wants to know what's your overturn rate and how long does it take to write an appeal? And those are two difficult questions to answer because there's so many things that go into it. But to write a simple effective appeal letter, maybe an hour and a half on average to write that. Is there any way to watch previous webinars without joining Prezi and paying for an additional license? Our previous webinars, recorded webinars, are on our AHDAM website, www.ahdam.org. They're free to watch. You should not have to join anything or pay anything. If you're having problems with that, let me know. You should be able to just click on it and it will start playing for you. Okay, let's see. I find more and more insurers want to apply criteria on day 2 or 3, and the patient's obviously not as sick on those days because of good management, especially with DKA, any suggestions. And again, I always go back to, you have to base whether the patient is in the correct status or not based on the time that decision to admit is placed. It shouldn't matter if the patient got better quicker than you expected, or I don't know how to. I know how to explain this, but sometimes it's a difficult concept, and payers certainly don't get it. Is that what is known at the time that decision is made to admit the patient is what should stand as the status indicator for that patient, sort of regardless of what happens afterwards. Although I did say, if one of the reasons why that decision was made to admit the patient is because of concerns for some risks happening, adverse events happening, and those adverse events happen, I will still talk about this sometimes in the appeal to help support that, hey, if the physician was concerned about this, and sure enough, it did happen, that helps support his reasoning to admit based on a risk of an adverse event. I guess is the best way to explain it. Do you include your reference to standard of care within the letter, just as you showed in your example, or more as a quoted narrative? Just wondering if you include all that information. So what we do is, let me go back to my letter. We do it the way that it's shown here. So we cite the source of the reference in APA format and where you can find it, so that if your payer, your reviewer actually wants to go, look at this particular guideline, they can find it. When we were doing a lot of appeals for Medicare, traditional Medicare, and going to the ALJ, I've had ALJs tell me, I read that article. I pulled that up and I looked at it, or he had his assistant or she had her assistant look at it, and help them understand why that's a standard of care. And then what we try to do is pull out just some bullet points and snippets from that guideline that might help your argument for why that patient needed to be an inpatient. So, the article's going to have, a lot of the articles are going to talk about a lot of different things. How do you diagnose? How do you treat? What medications do you use? That type of stuff. We just want to see what in the argument talks about when they should be treated in the hospital. And those are the pieces that we're interested in when we do our reference for the standard of care. Do you ever use case management notes as one of the sources when doing your fact finding? I do sometimes use those, especially, I honestly use them, or the notes when I'm trying to figure out whether, what happened with authorization for the stay. So whether they attempted authorization, it was denied based on the patient's presentation, and that type of thing. So that's basically what I use case management or sometimes notes for. Okay. Wow, lots of good questions. Lots of long questions. Good stuff. Okay, I'm going to stop there. We're just a couple minutes before the hour. I know some of you want to jump off and get your survey done. Just remember, if you want your CEU, that, close that down, to do that survey at the end. If you have any questions or something that you didn't think of today, make sure you email me at denise@AHDAM.org. There's so many questions today, which is great. Let me answer those we post a little Q&A with the webinar. It usually comes a little bit later than posting the webinar because it takes me a minute to get through all of the questions and give you some good answers. So you could go back, I'll put it out in our email, you can go back and read the answers to your wonderful questions today. So I'm going to stop there, and thank you all for attending, and we'll see you in June. Make sure you register for our June webinar, and I hope you all have a great day, and I hope you're enjoying your spring. I'll talk to you all later.